Hey everybody, welcome back to Stand By for Tones podcast. Like normal, you got myself, Isaac Baker, and our favorite guy, Mr. Sam Schwab.
Hello everybody, how are you? I say the same thing every time, man.
So do I. That's all good.
That's all right.
But welcome to today's podcast.
I'll branch out of my comfort zone there, but the hello will stick for now.
Hello, that's right. So, welcome everyone. We've got good stuff planned today, I think.
Yeah,
so
we got a fun-filled packed evening, or day, whatever time you guys are watching this. But yeah, we got a lot to cover. We're gonna go over a couple cases. I kind of got my nerd on a little bit. Kind of dove into some NCBI stuff. Hit the EMS one. What they've been talking about recently, and found an old one that I really like. That'll be kind of talking point number 2 here in a little bit. But before we get into that, should we remind them about our stuff?
Always. You can find all of our stuff on standbyfortones.com or sb4t.com. Both of them work. Find our critical care courses. We've got our 16-hour refresher as well as 36-hour intro to critical care. Get you through your flight medic. And don't forget to find our books on Amazon.
Yes, books as in plural. And another big thing, something exciting. Isaac just finished up the compilation of our brain dump sheet.
That's right.
Everybody kind of has their own going through school, but with some feedback from everybody and recent testers and trying to get new people through, we put something together.
Yeah,
it's free.
We did it totally free. So, yep, you can, if you just want a free brain dump sheet for your FPC or CFRN exam, go check it out. You can download it or get a hold of us and we'll get you a laminated one. So,
yep. No, not only is it good for that, it is just a really good resource to have. I mean, just having it sitting out on a desk, it's a good little refresher every now and again. So
it is. Good little study guide because a lot of that stuff, you study hard for and then you kind of forget some of it. So having a good refresher to look through and be like, oh, yeah, I remember what these lab values are or all these gas laws, all this stuff. So
exactly. And that's kind of the whole name of the game, right? That's why we're here is to continually bring hot topics, good refreshers, and things like that to everybody that needs it. And why don't we get started, man?
Absolutely. What are we talking about?
So the first one is here. I did my OR rotation recently.
Okay.
And I'd never used the McGrath video laryngoscope before, and it's fantastic.
Yes, it is.
It's light years ahead of where, because I was a reluctant changeover from the King Vision because I'd used it for almost 11 years and I had gotten the King Vision down. I know there's a lot of people that don't like it, but I was one of those people that did because I had practiced with it and done all the things. And then I did a bunch of direct and they didn't really have any blade options for the most part. We had, like the McGrath or the Mac 3, the Mac 4, they had a couple Miller sizes, but everybody over there pretty much had a Mac 3 for every patient. So, and that kind of led to some wheels turning, kind of thinking about it, because one of those things that kind of comes up in a lot of people's, practice is what blade size do I choose, right?
Correct.
Like I even asked our current educator from where we work, like we were going through our RSI training for my onboarding stuff, like as a neonate transport specific provider, how do you choose a blade for the kids? And but then that got me thinking, how do we choose blades for adults? And really what it came down to is it's provider specific, but there's data that backs which blade size is best in the adult population. And it's kind of surprising. It really kind of caught me off guard more than anything because, some people always think sometimes the bigger blades are better. You can displace more tissue. You can, try and get a better view. But some of these, clinical studies that I was reading that are, evidence-based and they have large, patient populations kind of say the other way. And, NCBI posted this one. It's less than a year old. It's the effect of laryngoscope blade size on first pass success of tracheal intubation in the critically ill adults. It was about a 1,000-patient study, and it was really good. It was really well written, and I actually really enjoyed it. And out of the 1,000 patients, 592 of them qualified for the study because they took out anybody that would need a blade size smaller than the 3. They took out pregnancy patients. They took out patients that were, in the ED getting emergently intubated. So this was a very controlled study
Correct.
to really be able to show us, the data behind it, which is really cool that they were able to publish this and put it out. And it blew me away. So really in the conclusion of this study is that they're showing that the Macintosh Blade 3 gives you a better Cormac-Lehane grading and a better visualization of the vocal cords and a better view overall of your anatomy than the Macintosh 4. It was just a study between the 3 and the 4 with our Macintosh Blade, which, it's a highly used blade, especially with video laryngoscope, because most video laryngoscopes are, there's some form of curved blade, whether they're displacing or non-displacing technology. We have that option to choose. Like even with the King Vision, you have an option of like the 2, the 3, down to the kid size.
Correct.
And then with the McGrath, we have everything from a 1 blade to the X blade. So we have every blade available in a Macintosh. And how do we choose?
Yeah. No, it's a great question. And, I'm not surprised that the 3 is better than the 4.
Yeah.
Personally, I think the 4 is just too big for most patients.
Mm-hmm.
Sorry if you're a 4 user, or if you're, I'm going to make fun of somebody. If you're Leslie Schutte, I hope you listen to this, Leslie, or if you're in Michigan, Leslie, make sure you give her a hard time, because we used to always give her the hardest time because she always had the biggest blade. Didn't matter if it was Mac or Miller. We'd always, at one point, I think we taped a flashlight on a canoe paddle and gave it to her and just called it the Schutte shovel, because she always took the big blade. But you know what? It worked for her. So I'm totally okay that she always used that blade in the adult population, because that's what she was good with.
Yeah.
So a lot of it, I'll get into my full opinion here in a minute on that stuff. But no, I'm not surprised. I've had just myself using the 4 or the 3. There's been a few times where I've been handed a 4 in the ER doing something.
Yeah.
And I get a CMAC 4 blade, and it's like,
this thing's massive.
It's huge.
Yeah.
And I've had issues with it myself because you end up going too deep.
Yep.
But yeah, I'm not surprised by that.
I just think that, with the 4 blade, more than anything, is like my mechanics change so much because there's so much of the blade left out of the patient itself that I'm having to use a lot more. Not that my forearms are little pansies or anything like that, but I'm using a lot more force than I typically would have to.
Yeah.
And I ran into that with the McGrath the first time that I used it, because I was super nervous going into an OR rotation. I'd never been in an OR rotation before, never had that luxury before. And I go in and, I throw this 4 blade on thinking, it'll be, kind of a routine intubation. I get in there and I'm like, holy crap. Like this is a lot of blade for even like the standard adult size. And not that it didn't go smoothly. It still went super fast. But after transitioning to the 3 blade after that, I was like, this is a world of difference.
So that's funny, because as far as the McGrath goes, I prefer the 4 blade.
Do you really?
For most people.
Yeah.
Yeah.
I do have to say, I only did the McGrath once when I was there, and it was with the 4 blade. Then everything was direct with a 3.
Gotcha. So the McGrath 4, if you haven't used the McGrath and look at the blades, I feel like the 4 blade is about the same size as a typical Mac 3.
Yeah.
So for the most part, if you're using a McGrath 3 blade on regular adult like you or me, I feel like you're going to have a little bit more difficult time getting the epiglottis, getting in the vallecula, or controlling the epiglottis, depending on how you're doing it.
Yeah.
With that 3 blade, because it's a little bit shorter. But
it'd be fun to actually go in and measure if it is an actual difference in length or size or anything like that. We might have to go pull one out, and we'll update the comment at some point and see if there's actually any difference between the two, like height and length or anything. But it was and that patient probably had a smaller mouth. It was a younger female, like a 30-year-old or 20-ish or early 30s female. So, a little bit smaller of an airway. But, the overall conclusion of this was really, surprising that they came back and, blatantly said, that patients intubated using a size 4 blade on the first attempt had a worse glottic view and a lower first pass success rate than patients intubated with a size 3. But how much do you think that comes down to technique at that point?
Well, a lot of it. That's, I mean, and again, get into my opinion on this. A lot of it comes down to technique.
Yeah.
So it's, for me, I mean, I don't care what blade you use as long as you know how to use that blade.
Yeah. I think a lot of it comes down to, too, is that we have to get people out of the jam and slam version of intubating, of burying that blade and pulling back until you see something. Because you should be able to be successful with either one of those blade sizes.
Correct.
And if you use the appropriate, that monotonous approach, it's not a monotonous approach, but I can't think of the word off the top of my head, but that nice approach where you're going in and visualizing each and every structure as you're going down, like you call out that I am controlling the mid part of the tongue, using your suction to help get that tongue kind of out of the way. Yep. You're going down, you see the posterior oropharynx, you see the tonsillar pillars, you see the uvula, you make the corner, you can see the tip of the epiglottis. You make your transition to an outward approach, and you should be able to, in theory, see all of the structures. I mean, depending on habitus and things like that. But I mean, like, you should be able to be successful with a lot of that. But how do we get people away from burying the laryngoscope handle and pulling back? I mean, like, is that just an old technique? Is that...
I don't know. I know I've definitely seen people do that. I know people that do that, and it bugs the heck out of me, and that's why
there's still people that do
we
it.
talk about it.
Yeah.
And if you've gone through any of our stuff and we teach it, it's, I mean, we call it following the path.
Yeah.
Right. Definitely. We follow the path.
Yeah.
And we give you the path to follow. Name those structures, go down just like you talked about, and get to that epiglottis and get your view.
Yeah. I mean,
right.
You have to go into this with a systematic approach. If you don't take that second to, procedurally pause yourself and say that I'm not just going to bury this blade and go in, you're going to bury that blade every single time.
Yeah.
And you're going to make your life a lot harder than it really should be. I mean, like, that's why we named it Follow the Path. I mean, like,
correct.
It's a path of least resistance in most cases.
It is. And that path leads you to the epiglottis. That's what's important. If you can find that epiglottis and get your first view, then you can become successful.
Yeah.
That's the way I look at it, is find the epiglottis, get your view, right? And then whatever view you have, there are multiple techniques to then improve your view. Mm-hmm. So if you start out and you get a grade 3 view, you should be able to change that to a grade 2 view.
Yeah.
If you're using bimanual manipulation, if you're, turning your turn your handle to the side a little
rock
bit,
to the left, just
left, right? Crike pressure by somebody else. Crike pressure. I like the bimanual manipulation.
Yeah,
and by that I mean I'm gonna put crike pressure down to the left or the right, wherever I need to improve my view, and then I have somebody take over that and hold that airway structure right where I have it.
Yep.
And then now I can put my tube in. So.
Yeah. No, and then, I mean, like, there's so many things that can go well and so many things that can go wrong, but we have to prepare ourselves in these situations. And that's why these clinical rotations and, this continuing education that we're trying to put out is so big. I mean, like, because I'm hoping that somebody out there is like, oh, maybe I should, take that extra second, not just bury, a Miller 4, Mac 4 or something like that as deep as I can, pull back, tear structures, cause edema, things like that make it harder to recover from, and that we can get people transitioning into this because, data doesn't lie. Math and numbers don't lie. And, we're going to link all of these studies down in our comments section or the bio of the episode there, so you guys can read them for yourselves because, that's one thing about data is that it rules. I mean, like, we can't deny it. I mean, like, there's always going to be variables to it. I mean, like,
correct.
How good were these innovators? Were they new resident physicians? Were they established CRNAs? I mean, like, there's a billion different variables to it. And then the other variable that I want to think about too is, I was such a King Vision user. Mm-hmm. Like, I loved having a single-handed technique. Like I used that channel blade like it was a freaking wizard. And I could, I could suction the entire time. I could bury my suction, still have my tube right there.
Yep.
I loved having a single-handed technique. But now I've fallen in love with our long-lost friend, the bougie.
Oh, yeah.
Like, holy shit, man. Like, like the bougie, like working for an agency where you had to use a bougie. If you needed a rigid stylet, fine. If you need that, but they wanted your first pass attempt with a bougie because it increases success rate so much, especially in the QED technique or the preloaded technique or something like that. I mean, like, it's incredible on how much we can improve our intubation success rate just by adding a couple easy steps of, following the path, adding a bougie into it, taking a procedural pause, allowing your medications to work, and slowing the process down a little bit and getting out of the rapid side of the RSI kind of
Correct.
side of things.
Remember, the only thing rapid about RSI is how the medications work.
Yeah.
All right. Everything else should be well thought out. Do your procedural pause beforehand. All your equipment's ready. But yeah, the only thing rapid in that is, again, how fast the medications work.
Yeah. And in a well-oxygenated patient, 30 seconds is a long time.
Yep.
Like, it is a very, very long time.
It is.
And
It's more than enough time to get it done.
Yeah.
And yes, I love the bougie.
Yep.
Have used the bougie for a long, long time. But only recently started doing the QED technique, which you introduced me to, and absolutely love it.
Yeah.
One of the things that I'm going to say about intubation and as far as which blade is the best is it all depends on you.
Yeah.
All right. When I went, one of the first times I went and did my OR rotation, the anesthesiologist that I was with, every single patient that he intubates, every single one, doesn't matter if it's you, me, your kid, anybody, is a Miller 2.
Oh. Okay.
Right? Is a Miller 2. So I had to intubate an adult female with a Miller 2 blade.
How'd that work out for you?
Freaking hated it.
But it worked.
Kind of. It worked.
Yeah,
I got the tube.
Yeah.
I also cut her lip, which pissed me off.
Yep.
Didn't make him happy either. But that's his technique.
Yeah.
That is his go-to. And I guarantee you, he's the best.
Yeah.
Right? Sure. That is his technique. He doesn't matter what it is, who it is. He can grab a Miller 2 and he can intubate anybody. But that's him.
That's him.
That's him. Right? That is because he's practiced it a million times. He's done it, 100,000 times on patients.
100,000 times more than us.
That is his technique, and he knows how to use that.
Yeah.
So for us, right, the biggest, most important thing is make sure you know your technique. Know whatever equipment you're using. Doesn't matter, right? If you all just got King Visions and you hate them, promise you the King Vision's awesome.
Yeah.
Just like a Miller 3 or a Miller 4 or a Mac 4 or a Miller 4, they can all be awesome.
Yeah. As long as you know how to use it and practice with it.
Yes. Right. So like I said, Sam introduced me to the QED, which I'll bring up a picture of that if you don't know that technique. But basically you're using a preloaded bougie.
Yep.
And I've tried the preloaded bougie before, and it's a pain in the ass because it was always the tube on the end of the bougie, and it's super heavy and awkward.
Yep.
But all you have to do is fold that bougie over and stick the end of that bougie just through your
distal eyelet.
Through the eyelet. What is that eyelet called? I forget.
I can't remember.
I can't remember. The eyelet on your ET tube.
Yep.
Right? You stick that over, so it's bent over, and now you just have a little bit of your bougie sticking out. You have control of your tube, and you advance, find your epiglottis, find your airway, advance that bougie through, pop the top, and slide your tube through.
Yeah.
And it works so good.
Yeah.
And my last 2 intubations that I've done this last month were both that way. But I didn't just be like,
So
that's a cool technique. I'm going to go try it on a patient, right?
Mm-hmm.
I can't tell you how many hundreds of times I practiced it.
Mm-hmm.
I'm doing it 20, 30, 40 times a day when I'm at the base. Every time I walk into the living room and I have the airway dummy just sitting there, I'm going to practice it. And I practice it not with only our video stuff with our McGrath blade.
Yep.
Brought our extra one down, made everyone practice with it. Same thing, practiced every single size of blade, 2, 3, 4 X blade, which I actually really like the X blade with it.
Yeah, I haven't had a chance to use. I mean, I've only used the 4 blade on that,
right?
Because I'm not lucky yet like you. I haven't had my run of innovations with our service yet. So,
but again, it's practice. I'm gonna make sure. For me, I'm gonna make sure that I have that technique dialed in. Before I go try it on somebody else, try it on actual human. So whatever you're going to be using, right? If you're struggling with that, that's on you.
Mm-hmm.
Okay. Don't blame the device. Figure out how it is that device works. How can you improve it?
Yep.
Right. Do 200 innovations on a freaking dummy.
Yeah.
Do it on multiple types of dummies. And I'm not just
Pediatric,
talking about
adult.
your partner, right?
Yeah. Get your company to pony up for something like a difficult area mannequin, like a Gumard or something like that. Shout out to Gumard if you want to be a sponsor someday. But I mean, like, yeah, Isaac, you're not wrong by any stretch of the imagination. I find that the hard part is, getting some of these, younger generationals and some of the generations that are stuck in their old way of finding comfort out of the norm. I mean, because like new paramedics are being trained on a little bit of direct and a lot of video, but then they go to a video that they weren't trained on in paramedic school. I mean, like, that's what happened to me, my first intubation. Like, my preceptor looked at me, was like, "You ever use the King Vision?" I was like, "No, but I'm sure I can figure it out." And it was an absolute disaster.
I bet it was. King Vision's hard and it's difficult.
It is.
Compared to normal techniques, right?
Yeah. It's
compared to
completely
direct
different.
and compared to like a CMAC or the McGrath. I remember the first time I picked up a McGrath, I'm like, this thing's trash. This thing's stupid, right?
Yep.
Love the McGrath.
Yeah.
I love it. I love it more than any other one that I've used now, but that's because I've practiced on it. I've gone through it multiple hundreds of thousands of times.
Mm-hmm.
No joke, because I'm not going to let my equipment basically dictate how this is going to be. So,
yeah. Have you heard of the tube forming thing for the McGrath? The where you take whatever size blade you're using. If you're using a malleable stylet, you place the tube on the bottom of it and conform it to the angle of the blade itself.
Correct. Yeah, and that's what I used to do. That's what I usually do for if I'm using a regular stylet. Is I'll just kind of form it to that blade real quick, and it works pretty well.
Yeah, yeah. That's what I did with the my first one because. I pulled out a bougie and he was just like, "What are you using that for if you're going to go with a video scope?" I'm just like, "You're not wrong. Okay. You're not wrong, but that's okay." And, but it seemed to work out pretty good. I remember because I in-serviced them for the ground paramedics, never had a chance to use it because I was in education, like on a live patient, I guess I should say.
Yeah.
But when the rep came out and was dealing with it, I mean, like that was a pretty slick thing. And I don't know if a lot of people understand, like, it all comes down, like you said, with your comfort level and what you want to do. But sometimes these little tips and tricks that either the younger generation that has trained so much on video or Laryngoscope through paramedic school or through another agency or something like that, don't just throw those little pieces of information by the wayside more than anything as they start to come out. And, because, I mean, we see a lot of that these days.
Oh, for sure. I mean,
it's going to, and it happens to me. I mean,
oh yeah.
Like there's been definitely times where I'm just like, my way is still going to be better, but I'll listen to you. But then it's like, I find myself adapting to the new ways and things like that. But it's just kind of one of those big things that we kind of forget about is like the simple things. How do we pick blade size? And now there's data to back it up and really not be able to argue with it.
Correct. Yeah, no, I think I've used them both and definitely find the Mac 3 better than the Mac 4. I think the Mac 4 is just too big, and a lot of times it's hard to follow the path when, I mean, you get the blade in, and now when you start to lift up and you're looking, like, it's so big that it's already in there.
Yeah.
And you're already past your normal landmark. So it just makes that much more difficult.
Yeah. And then just like the leverage itself, I mean, like it's just putting you farther away from the center of the mass of that you're trying to move. Because I mean, like the farther you outreach your arms and trying to get something heavy,
Yes.
the harder you're going to be working.
Correct.
And it's that same thing with having a longer blade. So,
yep,
not always is bigger better. So, oh man, do you think that covers it for the blade size there for the most part?
I think so.
I think so.
I would just once again emphasize whatever you're using, whatever your agency has, whatever you're stuck with.
Yeah.
Right. If that's the way you view it, like, get over it.
Yeah.
Get good at it. Practice, practice, practice.
Yeah.
Again, it is on you. If it's typically not an equipment problem, it's a you problem.
Yep.
So practice.
Yeah, that's how we ended up with the McGrath in our agency.
We do, and I like the McGrath better than the
too.
King Vision.
Oh, I'm not knocking on King Vision. I'm looking at you right now, King Vision. But I mean, like, because we have one to train with right there in this box ahead of me. But there is technology that seems to fit what we do a little bit better.
There is. And again, I loved and I hated the King Vision. I hated it because I found it too easy.
Yeah.
Like, I found Intubation so boring with the King Vision. It was just like, literally, you pop it in, it's like, oh, hey, look, there's an epiglottis. And like, oh, I mean, there's the airway.
The only time that you had an issue is if you were too close to the epiglottis or too close to the vocal cords.
Correct. If you're looking right at the vocal cords and that's all you see, you're not going to get in because you're way too close. But no, it was super simple. I loved it.
It was a great tool.
Yeah.
And, the one thing I will say, just final note on the McGrath, we'll tailor back to our little thing. The thing that I really like about it is that, you get a battery indicator of how many minutes of battery life you have left.
Mm-hmm.
And if you run out of minutes, it still illuminates the light for a period of time to use it as a direct blade, where you couldn't do that with the King Vision.
Gotcha.
Like, that was the biggest thing. Like, the biggest selling point for transitioning our agency from the King Vision to the McGrath was that you can still use it direct if you need to.
Gotcha. I actually didn't even know that.
Yeah.
So there you go. I learned something
So
new.
if the battery dies, the light will still illuminate as long as there's enough charge in that battery.
Cool.
But that's why we carry a spare battery anyways. So
perfect.
Yeah, you guys, big thing, just remember, use what you're familiar with. Continue to be good at what your agency provides you with. If it's direct, if it's video. I mean, there's still agencies that haven't transitioned out of, first attempt direct to first attempt video. So just take our little tidbit of information here. Like I said, we'll link this study because it's pretty astronomical findings. In my own opinions, they're pretty big for me. But when you're having a huge global healthcare network come out and say, "Hey, we did this study and it's big, and this is what we found," there's no arguing with it. So, on that, case number 1 complete.
Alrighty. What are we talking about next?
All right. So now that we talked about our blade sizes and everything like that, there's one that I found on EMS1 that is near and dear to my heart. And I'll actually give credit to, one of our paramedics. She left to go to nursing school, and I think is in CRNA school, is Jade, who came from Colorado as a paramedic service. And they had this protocol where they had to post ROSC, stay on scene for a set amount of time to stabilize their patient before movement. And that's something we never really explored where we, started our EMS agency. And that's a huge thing nationally. Like, you have an ill patient, a critically ill patient crashing in front of you. You scoop them up and go to the hospital fast enough, or as fast as you can.
Yeah.
Doing everything you can en route. I feel like
I hate that, by the way.
Yes. Yes. Thank you. Because, after we started changing it throughout our own agency, it made a huge difference.
It does.
And, the amount of rearrests that didn't happen because we stabilized on scene was absolutely mind-blowing to see the data from, 5 years previous to the current 3 years. It's incredible to see the changes in those things. And so Pennsylvania, this is a article from 2019, August 23rd of 2019. And I wish I would have seen it earlier. It's only like 8 sentences long. And it is like some of the best 8 sentences that I have heard. And why I didn't know more about it is beyond me. But
Right.
so they are required, or they set up a new protocol that says that they must stay at the scene of an incident to treat critical patients for an additional 20 minutes before transporting them to a hospital. They are required to do that. And
It's interesting.
It's interesting, but at the same time, I kind of love it.
I don't hate it. I'll say that.
Yeah.
Because again, I'm all about that critical patient.
Yeah.
Just giving them diesel doesn't work.
No.
Right? You cannot do good care with somebody trying to haul ass to the hospital.
Yeah.
Bouncing you around in the back. Right? I mean, how many times do you end up with all the H-bombs because of that?
Yeah.
The hypotension, the hypoxia, right? Or
hyperventilation.
Hyperventilation with all of that, because you just can't do great care.
Yeah.
But being able to be like, no, let's get a few things done. Let's get some vitals improved. Let's bring up their hemodynamics and avoid this stuff and actually resuscitate our patient right now, stop the bleeding, give the fluids, and treat your patient, right? It's the exact same thing they're going to do in the ER.
Yeah.
Minus X-rays and CT scans and blood.
Yeah.
Right? And that's about it for immediate interventions. And I mean, how many times do they go right to CT scan and they end up dying in CT scan because they haven't stabilized them enough anyway?
I 100% agree. And I mean, like, the way I look at it is we're in a very high level critical care service where we get to do a lot of cool things.
We do.
But how often do we stay on scene for 20 minutes or greater at a hospital to stabilize or continue stabilizing before we move?
Quite a bit.
Quite a bit.
All the time.
Like my last, I did a 7-hour ground leg. I guess a 7-hour round trip. But I mean, like, the patient leg was almost 3 hours. But we took, a solid 25, 30 minutes at the sending facility to get dialed in, to make sure that we had all of the resources we needed. We made sure we had all of the oxygen we needed because we're running 100% FiO2 with a high minute volume. I mean, like, the amount of spare tanks I brought with me was, couldn't ask for more. But I mean, like, it was a safety factor.
For sure.
I mean, like, we took that time, and it made our lives so much easier because it made us, I'd have to make an event adjustment here and there. We'd titrate a pressor every now and again. But, it's just one of those things where we got that initial stabilization for transport out of the way. So what is the difference between taking that 20 minutes when we're in the hospital, taking a high acuity patient out for 3 hours of ground leg versus, taking that 20 minutes on scene to treat your patient?
Nothing. It's the exact same thing.
It's the exact same thing.
Exact same thing.
But why is it so different? Why is it not encouraged for ground, but it's encouraged for us?
I don't know.
Do you think that's the counties saying, hey, we want you there in less than 7 minutes. We want transports faster. We want turn and burn. We got calls holding. Like
for us, I don't think it's a county thing. For a lot of services, it might be.
Yeah,
absolutely. Right. They always look at that. Like, why are they on scene so long? Or, you deal with families. I get it.
Yeah.
It's like, why aren't you getting them to the hospital? And it's, well, because if we move them, they're going to die.
Yeah.
And it's hard to explain that sometimes. And it's definitely hard to go back and look at your times and go, oh man, we were there for 30 minutes. Like, ugh.
You know what?
But it's, go ahead.
I'm going to tell you what I partially blame it on.
What's that?
Is people look at it as the longer they're with that patient, the longer they have to chart.
Well, that's true too. I don't care about charts, but that's just me.
Yeah.
You know me.
No, I know. But I mean, like, we're also in
a
lucky situation where, I mean, like, we have a set time frame where, like, you get 24 hours from the time of dispatch to get that paperwork in.
Yeah.
Like,
I don't do that. Right?
I know.
Yeah, I know. I understand charts, and we got to get things out to billing because guess what? We do have to bill people and actually make money so that we can get a paycheck. I get that. But I've I hate people. I don't hate people. Well, I hate people, but I hate it when I don't let charts dictate medicine
No.
for me. All right. I don't care if I'm down 27 charts. Like
I'll get
it
to 'em
doesn't
when I
it
get
doesn't
to 'em.
matter to me. I'm going to do them when I do them, whatever.
Yeah.
All right. And that's been my personal choice and decision in life for a long time, because I've seen people who don't want to chart and don't do good care because of charts and stuff like that.
Yeah.
So that is a good point. For me, it doesn't matter because
No.
again, I've made that decision personally that I don't really care about charts.
Mm-hmm.
Charts will happen. I'll get them done.
It's part of our job.
It's whatever, right? But
It's a necessary evil, as we shall call it.
it's totally evil, but for me, no, I don't give a crap about charts. I don't care. It's not going to affect my patient care.
Does it affect? I mean,
it probably
setting
does.
you
Yes.
out of this.
Setting me out of it, yes.
Yes.
I think that is for some service, sure.
Yeah.
Like our system that overcharts everything.
Yeah.
For medical director purposes,
Mm-hmm.
right? I mean, you will not find a simple chart, I feel like, in our system. If you do find a simple chart, it's getting sent back.
Yeah.
Right? We
Or it's a canceled
overchart-
route.
Oh my gosh. Overchart everything. But I always say, this is stupid, I don't want to do it, and then I end up like I cannot overchart.
Exactly.
Anyway.
But I'd be curious if anybody in this in the Pennsylvania area that's a part of this, required 20 minutes on scene. If you guys want to reach out to us, if this actually makes it out to you, maybe I'll contact you guys and see what happens.
Yeah,
let
I'm
us know how it
curious if
changed.
and if that's still a thing, even because that was 2019.
Yeah.
And like we both said, I'm surprised we've never heard of this. Like,
Mm-hmm.
because we absolutely love it, because we hate and we've talked about it before. Like, again, hate that you have to be gone in 10 minutes or 15 minutes or whatever it is, because it just doesn't work.
No.
And you do bad patient care when you're trying to hurry and move patients on and do everything en route.
Yeah.
When now you're stuffed in a moving ambulance or a
Mhm.
small helicopter or whatever it is, where you really can't do that good stuff.
Yeah.
So
Yeah.
no, I think
I frequently go back to this case that I had, and I tried to do everything in the house, and I walked in and I found this guy who is sitting in a couch, and he is blue, like from the diaphragm up, basically. So he's got that cape cyanosis that's either like
PE.
a PE, aortic dissection, anything that will limit blood flow upwards for the most part. I mean, like his lower half was still mottled and shitty, but I mean, like we walk in there and, I go, oh God, like this is bad.
Yeah.
Like we're going to be doing CPR on this guy.
Yep.
And, he's doing that panic, that, I'm dying type thing. Like maybe it's PE, probably an MI, just based off of kind of like his habitus and things like that. But, so we get the stretcher right next to him, get a blood pressure on him. It's, 100 systolic. We slide him over and he fucking dies.
Of course.
Excuse my language. I mean, like instantly too.
Inevitable.
Like we did every patient movement for him. But, this was, kind of mid-career, not necessarily mid-career, but I mean, like, it's just one of those things that kind of writes home in the back of my brain of like how important it is in those situations to treat them as they lie.
Yeah.
And, I learn from my mistakes. That was one of those mistakes that I will always learn from me, because I mean, like I take it into the critical care side of things now too, because how many times we move a patient from one bed to another and just see that 10 to 20 systolic blood pressure drop
All the time.
Just from simple movement.
Just moving them.
Yeah.
I hate that.
Yeah.
And it happens every single time. Like, I love trauma season, but almost all of my trauma patients, when you're working your butt off, giving them blood and doing all this stuff, and you finally get their vitals stable.
Yep.
As soon as you move them to that trauma bay, hospital bed, as
Through the
soon as you
toilet.
move them, they dump. And and that's just movement.
Yeah. And I, take the word required for what it is. I love that they have some form, if it's still going, of direction to prevent these things.
Yeah, absolutely.
Because it's huge.
It is.
I mean,
It is, and we've talked about the H bombs in our one, and that
Yeah.
resuscitation before
Yeah.
you need actual resuscitation, right?
Yeah.
And tanking these people up and doing stuff beforehand to prevent those H bombs.
Mm-hmm.
No, it's I think it's awesome.
Yeah.
I always have that hard time with it has to be 20 minutes because you may be able to stabilize in 10 or 15
Yeah.
and be ready to go. So it's the requirement. Like, I hate the exact
Yeah.
timeline
No,
stuff.
I get that. Like,
It's
like-
it's just like your TSC stuff. Like 10 minutes is all you have on scene. I hate that. Right? Sure, you
Yeah.
need to be able to move this patient rapidly, but being
hospitals
able to
also
do-
don't have to cut cars apart and try and get their
Correct.
crashing trauma patient out in under 10 minutes and go to the hospital.
Absolutely,
Like, those are unrealistic.
absolutely they are.
And, take, required for what it is. I think that if we could see something more like, in certain circumstances, prolonged seam time is more appropriate than a rapid transport.
Absolutely.
And encourage those longer seam times in
Yeah.
those situations and let provider judgment dictate when it is safe to move that patient.
No, I think that'd be awesome.
We're allowed to provider discretion our trauma patients. Why can't we provider discretion our scene times?
Yeah. No,
And,
I think so as
it's
well.
a big thing. And, I think that the world is moving towards that a little bit more, but hopefully we'll be able to move it a little bit faster because,
I hope so, man.
This is from EMS1. I'll link the 8 sentences in the, or I'll have Isaac do it because he doesn't let me touch computers. I'll link send him the link to put it in there so you guys can read it. But, it's good. I mean,
it is good.
and one of the things in here too, like just kind of backtracking here back to this story, in quotations, it says, unfortunately, in the emergency medical services, a lot of how people perceive us is based on how quick we are. Are we moving to the hospital fast enough? Are we just very super fast taxi cabs? And that's not where the industry has evolved. We bring the emergency room to you,
Correct.
said their assistant chief of EMS over there.
It's perfect.
And, another thing about this is just, like community outreach in that situation, letting your community know what your agency is capable of, because, if they have that perceived notion of, when they call 911, that they're going to get the best care,
That's a good point.
that's one of the things. Like, if we can limit that factor of the middleman there of rushing you out the door of, mom, dad, wife, husband, whoever it is at the time, trying to rush you out the door, and have that little bit of insight there first. I mean, it might go a long ways. So
I think that's a great point. That's awesome. Good idea.
that is also encompassed with a provider that is comfortable enough saying, hey, I know that you want us to move really fast. I know that's what we feel like we should be doing. But the more I'm able to do for your loved one right here and right now, the better chances they will to have a better outcome by the time we get to the hospital. And having those conversations is really hard because, we feel rushed, but we're trying to slow down at the same time and give them that chance to, understand what we're going through and how we're working through it and involving them in patient care, which is kind of, a hard art to figure out.
It is. Remember, you're not Les Schwab, right?
Yeah.
You don't need to run for stuff, right? All that does is get your heart rate up and make things worse.
If I was Les Schwab, I wouldn't be living in Idaho, that's for sure.
But, you're not a Les Schwab employee running out for service. I mean, it's okay to slow down.
Yeah. No, it is.
Take a breath.
And it helps in every aspect of our care just to slow down a little bit. Even in like the highest stress situations, and as much as the words procedural pause bother me for some reason, it's just kind of one of those ick words for me, like how people don't like moist, like
or creamy.
But I mean, like, it's just one of those, it's just kind of one of those ick words to me. But I find myself on almost every patient taking that little mental silence break of like, okay, this is what you're doing. This is what you need to be doing. This is how it needs to go. And now act.
Yep.
And taking that 10 seconds of just me time in those critical situations is huge. And
It is, and
it changes my game 100%.
it does. And don't be afraid to call that out to not only yourself, but to everyone. Just be like, everyone stop, shut up for a minute.
Yeah.
Relax. Everyone take a breath.
Yep.
This is what's going to happen. Sometimes that's super important.
Mm-hmm. That's when I get in my own mind and say, you freaking got this, man. You got this. You can do it.
You can hype yourself up.
Yep.
You can say a prayer, whatever you need to do,
Mm-hmm.
but just take a breath. So,
Yeah.
and take your time on those critical scenes, because again, throwing them in the back of a ambulance with somebody trying to haul ass to the hospital and going around every curve way too fast, throwing you across the ambulance, it doesn't help, and it doesn't work, and it doesn't help your patient. So,
yep, we can.
Awesome.
One of those things. It's just slow is smooth and smooth is fast.
That's right.
The motto of as much as I hate to say it, the fire world extraordinaire. So, oh man, how much time we got left tonight?
We're at 46 minutes right now.
We're at 46 minutes. We got time for
we're gonna I think answer a question.
Yeah.
So from one of the critical care groups that we follow.
Should we tell them what we're doing here now? Adding this in here?
Sure.
Yeah. So we're kind of talking about what we needed to do and kind of engage listeners a little bit more. You can ask questions to our Facebook page.
Absolutely. Please do.
I am heavily involved with a lot of the flight paramedic and nurses groups on Facebook, the future flight paramedic and nurses group on Facebook. And I try to go through and comb through questions because, as much as I dislike Facebook, I like it for what we're doing now.
Yeah,
right?
for sure.
And so we're going to try and comb through and just find just a random question. We're not going to say who wrote it. We're not going to do anything like that. But we're going to go through, and whether it's got 100 responses on it or it's got 0 responses on it, we're going to try and give the best advice that we can give from our seasoned selves.
Correct.
So, did you write down the question, or do I need to read it?
We can kind of paraphrase it real quick, but the big question is talking about RSI for somebody who is basically already self-sedated and basically just has trismus. All right, they're out of it. We're going to need to intubate them, but they're completely out. They're trismused up. Is this do you give the paralytic and the sedation, or just the paralytic?
Yep. I love it. It's a great question.
Great question.
And it's a question that, haunts paramedics in their early stages. Yeah. And, I've gone through a bunch of different variations of how to treat this patient. I think I finally landed on one, but who wants to go first on this answer? Because I know we're going to have differences. We're going to agree to disagree on some things, and that's just part of, medicine in general.
Correct. So I have my opinion. So for me, if I'm going to do an intubation and they're not dead, so I'm doing an RSI.
Yep.
I'm doing the full RSI.
Yeah.
Every time.
I can 100% get on board with that.
Yep. So I don't care if they're, again, they're fully sedated on their own, or just failure, airway failure, right? Respiratory failure. I'm going to do an RSI. I'm going to do everything. Yep. I'm going to do the rock. I'm going to do the Tomidate or the ketamine, whatever I decide to choose.
Yep.
And do it all.
Yeah. I am 100% in agreement with that. The only variation that I change to that is I calculate my shock index. So I take my heart rate divided my systolic blood pressure. Mm-hmm. Okay. If it's greater than 1, I am going to give, and this was heavily trained on from a previous agency, and it seemed to work really well in keeping hemodynamics up because when we get a higher shock index, anything greater than 1, they have a really high chance of morbidity and mortality with a lot of the procedures that we perform and just recovering in general. So what we were trained to do is that we will double our paralytic dose because we're going to have a less of a chance of, hemodynamic disruption with our paralysis in general.
Correct. And you're going to have a harder time for paralysis to actually take effect because the hemodynamics are low.
Exactly.
Right? Yeah.
So we're covering our bases on 2 there. So we're over-wetting ourselves in the rain, basically. Like we're walking through that rainstorm there. And then we're going to have to, if they are obtunded, like a GCS of 8 and down, we're going to half dose our sedation for our induction agent just to keep our hemodynamics a little bit more stable as we go through it. That, or we go a DSI route where you give, your sedative, you get them relaxed, and you give another dose of your sedative, or you give them your pain control, then your sedative, and then you give them your paralysis, and kind of do it over time as you're treating their hemodynamics at the same time.
Yeah.
But I found that in the last couple, critically ill patients that I helped take care of over my old agency is that, walking into it saying, big sick, what's my shock index? Okay, we're going to go with this medication. We're going to double it, whether it's rock. We didn't use suck, so it was just rock. And then we're going to half dose our medication. Left us a more stable patient. Even after push dose epi, starting of vasopressors, we didn't have that significant dip. So I 100% agree with the full-fledged RSI every single time. But it's patient dependent on their hemodynamic status, on how much sedation and pain control I'm going to provide right in the initial setting, if that makes sense.
It does, and I have no problem with that.
Yeah.
The only issue I have, and I don't see it a lot with EMS providers, but I see it a lot in hospitals, is where they don't want to push that paralytic, and so they're going to do a ketamine only or Versed only or whatever it is,
or
intubation,
or they're going to do we sedated with sucks.
No, my problem is when they don't use the sucks or the rock, and they're only using sedation medications to try to intubate these patients. And I promise you, you will have many, many more problems if you don't push that paralytic. So push 100%. The paralytic. All right. You're not going to have vocal cord spasms. You're not going to have somebody trismus up, gag reflex, all of a sudden vomit, bad things happening because you didn't push that paralytic. So do the full thing, paralyze your patient, sedate your patient, get them intubated.
Yep. Use your Miller 3 or your Macintosh 3.
Your Mac 3. You messed it up.
I messed it up.
No, you're good.
Your Macintosh 3. But ladies and gentlemen, that's what I got for you tonight. Save our third or our fourth case or question for the next episode here. It'll be a riveting conversation on the use of pre-hospital ventilators.
Yeah. And
I'm actually really excited for that one, kind of, probe some questioning out of people. So that'll be pretty cool to see what people are doing out there.
No, for sure. But nope, that's, I think a good one. So
yeah,
thank you guys for listening in. And like always, stand by for tones.